TopMedTalk.
Welcome to TopMedTalk. This week we're looking at a very popular moment from Anesthesiology 2022, which of course we brought you coverage of. It's a conversation about the big picture theme of TopMedTalk, Perioperative Medicine. It begins with Desiree Chappell, Monty Mythen and Sol Aronson introducing their guests, BobbieJean Sweitzer and Angela Edwards.
Dr. BobbieJean Sweitzer and Dr. Angela Edwards. Ladies, thank you so much for joining us. Tell us where you're from and about your practice.
So I am currently an assistant professor of anesthesiology at Wake Forest School of Medicine in Winston-Salem. I have served as the medical director of their pre-op clinic, section head of Perioperative Medicine, and I am currently serving as the vice chair of professional affairs. So didn't quite leave those hats, just sort of scooted onto some additional things, and it's all great because I still practice in the pre-op clinic and I still maintain a presence in the OR, and it's been rewarding all the way through. So I do a few things, but not nearly as much as
both of you guys do. Both of you guys do.
And I was privileged to visit recently. Awesome.
Yes, it was a pleasure.
Awesome setup.
Yeah,
a
that's
research
fantastic.
Powerhouse as well.
It is fun, isn't it? Yeah.
What a team.
It has not stopped.
Okay.
Wow, I'm so impressed.
Thank you for having us.
Yeah, absolutely.
It's delightful.
BobbieJean, you've been with us quite a bit over the years, for sure, especially at our EBPOM meetings. You transitioned in the last couple of years.
So I took a position as a professor of medical education at the University of Virginia, and I'm the systems director for Inova Health Systems, which is in Northern Virginia, just outside of D.C., which is one of their major teaching hospitals. And I oversee 5 hospital-based preoperative clinic and really starting a perioperative process with, integrating ERAS protocols and various optimization opportunities.
Yeah. BobbieJean, you've been a pioneer in this space and done so much work here. Tell us just very quickly your work whenever you're at Northwestern, all the different things that you're doing in the perioperative and specifically the preoperative space, because you started and ran a clinic there, and I think it's so interesting.
I was really lucky. I trained in internal medicine first. I practiced medicine for about 5 years, and I did preoperative evaluations, and I took care of my patients, I thought, well. And then I decided to train in anesthesiology, and I was very embarrassed. I think I realized that I really didn't know anything about preoperative medicine. The evaluations I'd been doing were completely worthless to the anesthesiologists, the patients, and the surgeons, and especially that whole perioperative team. So, I was just lucky, I think. It was the right place at the right time. This was kind of an emerging field. Hospitalists were taking over sort of inpatient and postoperative care. So the primary care doctors and PCPs were, becoming more truly outpatient. I think they were less involved with acute care medicine on all levels. I think as surgery advanced and we just offered so many more procedures, and some of them safer, the laparoscopic, the robotics, and then the patients got older and older. I think it was just a need to better evaluate, optimize patients. So at Northwestern, when I went there, we actually, evolved and started an anemia clinic, and we gave IV iron on site. We, started penicillin allergy testing so that we could improve the most appropriate antibiotic the patient got for the day of surgery to lower surgical site infections. And I want to hear what Angie has done as well, because it's just a lot of us, I think, and it's just exploded beyond my imagination of where pre-op could go.
Yeah. And Angie, you as well, pioneering in this space. I mean, you've done a tremendous amount of work.
And Bobbie provided the perfect segue, both truly in full form by sort of setting the stage for preoperative optimization. I think we're right now at the ASA and with anesthesiologists, we're seeing a robust interest in preoperative medicine, preoperative optimization, because it really coalesces all the work that's been done with enhanced recovery and medical management. It's the things we've trained in, the things we know, and we bring that forward patient-facing to truly provide higher quality care and be more patient-centric. So anything from looking at the care of our aging patients, caring for vulnerable populations, anemia management, comorbid conditions, that's sort of the foundation for everything. But I think what we're seeing here and what I've seen with the program is there's so much more interest. Clinicians are realizing that unless we take care of these patients before surgery, we cannot improve outcomes.
Yeah.
I attended BobbieJean Schweitzer's lecture yesterday, and it was packed to a packed house. So just that alone was very telling to me that there's a robust interest in things that we need to ask our patients, things that patients need to tell us, and actually what we need to medically manage before surgery.
I've heard great things about the track. You even had a track or a whole day of just perioperative medicine, right?
You know, it's actually scattered throughout the entire program.
The
but
track.
we had the topics are exactly the ones that I would have mentioned. So and a lot on preoperative optimization and technology. So meeting these patients where they are. I think COVID provided opportunities that we're now seeing. A lot of our patients are used to interacting virtually, so telehealth, and even our aging population by proxy with their family members. So you have an opportunity to see truly what the patient's home environment looks like, ask about their medical conditions, and probably recognize that they've not been out for very long. And so while we're gradually coming out from under, I think patients still want to be in touch with their preoperative optimization process at home, because they're going to come into the hospital just for their surgical procedure. Whatever we can do to meet them at home is ideal for them. And I just attended another session recently on just that topic. That's preoperative optimization and digital technology and how we can merge the two.
So, Angie, BobbieJean, if you could both comment on this. It sounds as though perioperative medicine is being fully embraced now by Team Anesthesiology.
Yeah, and Randy talked about how the ASA is embracing it.
You can comment on that in a second. And part of embracing it now, you know our journey back in the United Kingdom, the Royal College of Anaesthetists baked perioperative medicine into its training program. Our training program is much longer. We got approval from the General Medical Council, so we're uniquely trained as perioperative physicians, and other people can match that training. And there are long-established now masters in perioperative medicine. How do you think it will unfold here?
That's a fun question. So if you look at where we currently are traditionally with our education to become board-certified anesthesiologists, there are sparse elements in there with preoperative optimization. I suspect as we move forward, and we've already embraced the elements of enhanced recovery, as we bring forth more medical optimization and prehabilitation, I think we'll see more of that along the way. But will we expand the educational time frame? It may or may not be worthwhile. There are fellowship opportunities, and so we'd be more in keeping with expanding 1 year beyond the traditional training, or incorporating more of that into our 4-year block.
Because our fellowships became the most popular. So the Masters was the most popular Masters at University College London. The MOOC that was launched, the Massive Open Online Course, went into tens of thousands very quickly. And the applications for the Perioperative Medicine Fellowship were the highest number of applications. Is it being that embraced here yet, BobbieJean, or do you think it's a longer journey?
And I think it is starting to be that, exactly. So, I think we could learn so much from people outside of the United States, the way, especially in the UK, how anesthesiologists have a very different role, I believe, in the care of perioperative patients. And I think we have just never done that before in the United States. So, I think a few years ago with, embracing sort of the perioperative surgical home was some efforts to kind of do that. So there's a new ad hoc committee on perioperative medicine here at the ASA. And they're, diligently working. In fact, one of our good friends, Gina Blitz, who's at Duke, runs a prep clinic there, is, one of the leaders in that group of developing a curriculum. And a lot of it's based off the work that Gina and Angie and others did in SPACI, the Society for Perioperative Anesthesia and Quality Improvement, which has a virtual fellowship. That's the second year now. Correct me if I'm wrong. The second year of
just graduated our first class.
Right.
Yes,
Congratulations.
That's a 9-month program that was very highly received. So a lot of that is being taken from what you guys have done, what others have done, what SPACI has done, to develop a core curriculum and competencies around what it means to be a true perioperative, and focus on the preoperative, because I think we have ICU doctors, we have pain doctors, we have others who can help us with the postoperative period more than we have people in the pre-op. Ironically, even the internal medicine training here has nothing on preoperative medicine. So a few years ago, the ABA deemed that every anesthesiology resident needed to have 4 weeks of preoperative medicine. But it doesn't mean it has to be in a preoperative clinic, and doesn't mean it has to be, directed by an anesthesiologist in a preoperative clinic. And then a few years ago, they actually decreased that requirement down to 2 weeks. I think the ASA feels that is, not going in the right direction. I think they're already reaching out to ABA, they're reaching out to others to both develop a fellowship that would be a postgraduate after residents finish their anesthesiology, but also to bolster and have a true curriculum and competencies within the residency itself.
Because ours, which I think they did a pretty good job, is spiral. So you do, core, intermediate, and some people do advanced. But everyone does core and intermediate. And the advanced component of it is in the same way as you might have aspired to become obstetric mainly, or pain, or cardiothoracic. You say, I'm planning to be a perioperative physician, and that terminology's crept in as well to distinguish to sort of my objective is to be a provider who does from moment of contemplation, blah, 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 and not scared to use the perioperative physician language, which is...
I think we will get to that point. Yeah. I mean, to Bobbie's earlier statement, there are currently perioperative medicine fellowships. There are about 9 or 10 in the country right now, and each one is distinctly different. It's after an anesthesiology residency. This one with SPACI is entirely virtual. It's at least 2 or 3 hours per week of one-on-one or one with a group discussing a particular preoperative optimization topic. And it's been widely successful in terms of the application pool. We're relatively limited, but looking to expand in the coming years. And this past class has been tremendously successful in setting up their own preoperative processes. The nice thing is that we've also pulled in sort of a multidisciplinary group to provide the education, and it's actually international too. So we have a large international, an increasingly number of international applications coming forward.
I was just going to ask. So you said multidisciplinary team, because I know that you guys are multidisciplinary in SPACI, and so who is eligible to take this course or this fellowship?
So everything's available on the website. In fact, you can just look on the SPACI website, the fellowship, all the information is there. And it's really an application process. So for those who are currently working in that preoperative optimization space, because there's a capstone project, you need to have the available location to implement a change or
QI kind of thing.
Correct. And so that's the capstone. That's the end of the program, which is usually in September, October.
But I think most importantly, it's not just for anesthesiologists.
Oh, okay.
It is for, I think it's only just for physicians, correct?
At this time.
But it is open to, you can be a surgeon. You could be a primary care physician.
Do you have any currently that are non-anesthesiologists?
We do.
Oh.
And that's actually what makes it more robust. The conversations each week are phenomenal because everyone comes to the table with their own perspective, their own background, and sharing information on Thursday nights at 8 p.m. Eastern Time. It's been tremendously successful, and I think everyone's gotten more out of it than they anticipated, including those of us who are teaching.
Yeah. Oh, that's always the case, isn't it, Monty? I feel like we've talked a lot about that.
Absolutely. People are starting to appreciate what a wonderful career opportunity it is as well.
It is absolutely a career opportunity, especially, in the space in the United States, right, where we have various professionals who can deliver anesthesia services. And increasingly even, non-anesthesia trained, be those dentists or interventionalists that are giving sedation and conscious sedation in nurses. I think, we want to make sure that we're relevant as anesthesiologists and that we really leverage our training. I mean, we're going to medical school, we're doing these full, residencies. And I think it's just a wonderful opportunity for career development. Yeah. And it's so important for our patients because there really is a void. I mean, I mentioned how, internists do not get trained. There's no curriculum in internal medicine training. There's no curriculum in cardiology for preoperative evaluation and practice. There's people who do it grandfathered in. They write some guidelines in different specialties. Especially coming from the world of internal medicine to the perioperative, it's very different. We're not trying to, improve care over the lifetime or a year or 10 years or preventive care. And it's so important to be able to weigh, I think, that you don't want the cure to be worse than the disease. So while you're waiting to evaluate a cardiac situation, if the patient is deteriorating, or if you don't consider that, well, if I don't do this basic simple colonoscopy on this bleeding patient, but I want to send him to cardiology who wants to put a stent in, which will require dual antiplatelet therapy, doesn't exactly line up, right?
Yeah, sure.
I think Bobbie brings up a really good point. We all went into medicine to have an impact on care, and we're really fortunate in this space. As anesthesiologist in the holding room, I have limited time to interact with my patients, whereas in the pre-op clinic, I have the great fortune of having 10, 20, 30 minutes. In fact, sometimes I get in trouble because we're talking too much. But an opportunity to actually make your patients feel better, have an understanding of what's getting ready to happen. and ask questions, whereas you don't have that opportunity. And then sometimes it could go on for several different episodes because we do, again, improving medical conditions or interacting with primary care physicians or even their surgeons. We're oftentimes very involved in their care, much more so than we would be in the holding room, to actually improve outcomes and actually make their process much better.
Yeah.
Can I have one more question? Very complicated area. We've discussed it a little bit before. I know you're passionate about this, BobbieJean. Is proceeding to surgery is not always the correct endpoint of a preoperative evaluation. Could you both comment on that?
BobbieJean first, I'll let you.
Yeah, I think what you're getting at is that, I think that it's important that we make sure the patient, consider obviously the surgery, but, we know that in the United States, at least, about 40% or more of surgeries we do are considered completely elective surgeries. And so they don't have the time sensitivity or urgent nature. And so you really have to weigh those patients particularly very differently, right? And immediate anesthesia and surgical care has become very, very safe, but not necessarily the recovery periods and the improvement on quality of life and what it takes. And so I think part of that too is what we do in the preoperative clinic is making sure that those patients who are going to have their total knee replacements understand that, they can't go home and go upstairs and sleep in their second floor bedroom. We are careful that we weigh the correct timing of surgery, the correct venue for surgery, even the correct team. We need to make sure that cardiologists who specialize in pulmonary hypertension is going to be around when that patient now has their surgery. But then also, really engaging the patient in shared decision-making of whether surgery is really, they've considered all the alternatives and they've considered the downside, perhaps, of what can occur with surgery, or even the time and effort it takes to recover because they'll have a wedding coming up or something that,
Angie, where are you building in this concept into the fellowship, or has it been built in?
It is. Actually, the entire curriculum is built. So every week has a new topic, several readings, and it's part of our shared decision-making conversation. Bobbie also sort of touched briefly on the added value that we provide in the preoperative space. It's easily quantifiable, which is actually also important to demonstrate to administration to support what we do, because there's time, personnel, and space involved in having a preoperative space or even doing telehealth. But in terms of the curriculum, this is built throughout. So our curriculum is designed such that we start out with the fundamentals of aligning with the question, looking at potentially, publication, and then we go through the basics of a pre-op clinic, how to set up a process, how to set up staffing models, and where to put the process, probably about 3-4 sessions. And then the rest runs the spectrum of what's involved in clinical practice. And towards the tail end of things, we always cover enhanced recovery topics. We always cover the cardiopulmonary exercise testing is one of our topics at the end of the year. And we sort of build it throughout the year, and we have some flexibility in the system towards the end of the curriculum, which is usually about July, to add additional topics. And each week, all of our fellows are paired with a mentor. So each week, those pairs meet up as well to have additional conversations around their capstone or issues they're having in their preoperative process or questions they're having regarding the fellowship.
And the concept of shared decision making is something that you've just it's infiltrated.
It is a specific topic for a week.
But
it's also built in. So we have a focused topic each week, but as you can imagine, conversations go anywhere. So we open things up.
And Angie, you mentioned, I think, cardiopulmonary exercise testing. Is that getting traction in the preoperative evaluation space?
No.
Not yet. Okay.
It's part of our curriculum. Like everything else, it's all resource-based, so it's certainly part of the educational curriculum, but in terms of implementation at each center, it's very different.
Yeah, for sure. Well, ladies, I always love to catch up with you guys and know. So tell me, what is the latest that you're working on? I'll start with BobbieJean.
Thank you for asking. I just had an article actually published on Anesthesiology on a topic that hasn't been covered well, is the patients with ophthalmological diseases and the impact of that on intraoperative care. And so relatively, I would say, not commonly, but very often encountered. But because they're not sort of in people's top of mind as something, we've taken
things like glaucoma and macular degeneration. And,
and the ones at risk for blindness and positioning, especially with
all the anesthetic risks. Steep T
so we chose another organ, and I've been sort of on an eye thing. So at the December 2021 issue of Anesthesiology, I was the lead author on an article on the perioperative care of cataract patients.
Really?
And so we published that as a guideline from Society of Anesthesia, Ambulatory Anesthesia. So I really urge people to take a look at that because it's a very kind of practical how-to.
Yeah.
Like, is it okay to proceed depending on the glucose level? Or if you have newly discovered atrial fibrillation the day of surgery, is it safe to proceed with a cataract surgery or not? And then what's coming down the pike is I'm working on a paper with Samba folks on safe dental care and safe sedation in the dental space specifically.
Yes.
Which, we've had some unfortunate situations in the United States of some people. Poor, very bad adverse outcomes. So we're working on that.
Great.
And then there's a SAMBA guideline on glucose management in diabetics coming out soon.
I don't know how you do it all. Sure. Angela, what about you? Because I know you're always up to some amazing things
thank you
as well.
for asking. Most of my work right now is on education. So we're doing a lot of work across different preoperative spaces, both in my region as well as across the Southeast, trying to improve preoperative optimization and processes and at least unify what we're doing. So care of the aging patient, preoperative anemia. Everyone's sort of adopted enhanced recovery, but what does that mean in terms of nutrition and rehabilitation and cognition?
Yeah.
So that is sort of the focus. With SPACI, we've got some exciting things coming out. I have to sort of be fairly covert, but we've partnered with a lot of our members and looking at their preoperative processes across the spectrum of our membership to see if we can establish a best practice for preoperative clinics and preoperative programs.
All right, very good. Liz, I'm always so impressed to talk to you and hear everything that you're doing. And thank you for everything that you do.
Thank you for having
and
us.
the inspiration we get from you guys. So
Don't forget, of course, the links to the full unedited conversations are available in the show notes.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.